Good morning, everybody. So next we'll be talking about mastering panretinal photocoagulation for PDR. So why PRP? So initially you had two landmark studies, both the DRS and the ETDRS. DRS established that panretinal photocoagulation, it prevents severe visual loss, and ETDRS said that it should be reserved for high-risk cases, avoiding mild and moderate NPDR. PRP mainly works by increasing the retinal oxygenation. It increases the diffusion from the oxygen from the choroid and also eliminates the hypoxic areas and vasoproliferative factors. Now, what are your indications? When do you do PRP in diabetic retinopathy? So mainly you have four indications. So you have neovascularization at the disc, neovascularization elsewhere, any pre-retinal or vitreous hemorrhage, and in advanced PDR development of neovascular glaucoma. Now, traditionally PRP is basically given either through a slit lamp delivery system or even through an LIO. And the various power settings, it can vary. Power can vary from 200 to 600 milliwatts depending upon either the retinal pigmentation. If your pigmentation is a more heavy, it requires lesser power, whereas a lightly pigmented fundus will require more power to get the burn. Other factors include a media haze, the patient has cataract or vitreous hemorrhage. It requires more power to get your desired burn. The spot size will be fixed on an LIO, depends upon the contact lens use. Duration can vary from 0.5 to 0.2 milliseconds. Intensity, you ideally aim for a 2 or a grade 3 burn, grade 1 being just visible, grade 2 being faint white, grade 3 being dirty white, and grade 4 being a chalky white burn. And distribution ideally should be at least one burn width apart. And number of sessions, you usually aim for a two or three sessions. And with a CKD patient, you ideally go for a 3 sessions per eye. Now, where do you laser? So basically, you have two fixed points in the eye. You have your optic disc and your fovea. So and because diabetic retinopathy is a posterior disease, you ideally require very good posterior laser. So it should be 1 disc diameter nasal to the disc, 3 disc diameters temporal to the fovea, and at least 1 disc diameter above and below the vascular arcades. Now, how do you laser? So getting a good posterior laser is very important. So the technique especially when you are starting out, you ideally need a good demarcation before you start lasering to avoid too excessive posterior laser. So first you take your slit, make it into 1 disc diameter, enlarge it so it becomes 2 disc diameters. And move the slit nasally so that now your spot size will be 1 disc diameter nasal to the disc. Apply your laser marks and get a border extending to the nasal area. Similarly, laser it inferiorly. Now switch off your laser beam so to avoid any accidental foveal burn. From the fovea, take your slit lamp, move it again so you can get a 3 disc diameter width. Apply your laser burns and get your temporal laser marks. This is again followed by your inferior laser boundaries. So now you have, when you're starting PRP, get your boundary done first so that you avoid any posterior laser. This is also followed by a fill-in PRP in that area to get that correct 180 degree. Now, what do you do when you have fibrovascular proliferations? So still PRP is essential because it reduces the VEGF drive. So it reduces the progression of the fibrovascular proliferation. It stabilizes the existing fibrovascular tissue, reduces the risk of VH, reduces chance of TRD progression. And also prior to surgery, it can induce PVD, which is helpful. It can reduce the intraoperative bleeding risk and lowers the risk of postoperative recurrent hemorrhage. When you have fibrovascular proliferation, ideally you should aim for a 3 to 4 disc diameters away from the FP, so to avoid any further traction on the well. Now, what happens when you have a vitreous hemorrhage? So the flowchart I usually like to follow is, if your view is good, then you do a full PRP. Now, if you have a partial view, you can do an accessible PRP to the visible areas, reassess the patient after 2 weeks. If the view improves, you can very well do your completion of the PRP. If still the view is bad or if it worsens, your options are either vitrectomy and endolaser. Now, what if the patient there's no view? First, you do a B scan to rule out any TRD or a macular TRD or a combined retinal detachment indicates a need for a vitrectomy. If there is no fibrovascular proliferations or a TRD, you can give either an option for an observation or even an intravitreal injection to the patient. If it resolves, you can go for your PRP. Still, if it's not resolving, then vitrectomy and laser is your option. So there's another term which we say it's called an add PRP. So these are additional PRP or a supplemental PRP. We do these when you have neovascularization persisting, where there's missed skip areas, or if the PRP was incomplete, either due to patient-related factors, or if a cataract was there and now after the cataract surgery the view is better, or even there is progression of the PDR. We do add PRP mainly either to the mid or the far periphery or in areas of non-perfusion or even between the PRP burns. So there's another new machine, relatively new, called Pascal. So this is a pattern scanning laser. So it's a semi-automated multi-spot burn patterns with 20 millisecond duration. It has less thermal damage, less burn speed, and it has better patient comfort and safety. But some studies have suggested they'll be more likely to have a recurrent neovascularization or require additional PRP for PDR. What are your signs of an effective PRP? You have your neovascularization regression. You have mature laser scars. These are with no skip areas. There's hemorrhage gets controlled. There's no new hemorrhage or resolution of the vitreous hemorrhage. Your anterior segment stabilizes. Your NVI regresses, or even retinopathy stabilizes. The complications you usually face are either vasovagal attack, reduced contrast and color, can have peripheral visual field loss, decreased night vision, over-enthusiastic or excessive laser can result in choroidal detachment and exudative RD, pre-retinal membranes, and even accidental foveal burns. The other options which are newer include a subthreshold micropulse laser. These mainly act by stimulating the RP and preserving the retinal structure. But they may require multiple sessions and it's a less predictable and slower risk of neovascularization. Overall, conventional PRP is still the gold standard for high-risk PDR. Thank you. If you have any questions, please. Please.
Nice job, Mr. Sir.
Thank you.
Sir, I have two questions actually. For Pascal pan-retinal photocoagulation, do you recommend the pattern like 5x5, 3x3 like that? Because I have seen my seniors doing 5x5 like, and the laser marks are not so expanding. As you already told, it is less expanding. So I felt it like 3x3 or lesser pattern will have a better impact. And the scar, for usually we keep one burn spacing. That is for the burns to expand. So if we keep a Pascal like pattern, do you recommend less spacing
Not
or effectiveness?
Not necessarily, because your burns will be still in that pattern, even if it's a bigger pattern. That means still your burns will be correctly placed. Only thing is it's faster, less patient pain will be there. There is a lesser, most likely you'll require more additional PRP will also be
I have
required.
seen patients coming for more ad PRP after a Pascal than a lesser.
I still prefer single spot. It may
Single
be.
spot. Thank you, sir.